Mrs. Ismehat Ashrafiridi, a 30-year-old housewife hailing from Sylhet, presented to us with history of thickening and tightening of skin for last 6 months, multiple joint pain for last 4 months, and shortness of breath with cough for last 2 months. According to the statement of the patient, I think it's too cold. According to the statement of the patient, she was reasonably well about 6 months back. Then she noticed thickening of the skin of her hands. Thickening was also associated with tightening, and that gradually progressed to involve up to the elbow. The thickening and tightening also involved her face and the legs up to the knee. Those symptoms were associated with change of skin color after exposure to cold water. And initially, the color became pale, then became blue, and then the color changed to red. So she had sequential change of color after exposure to cold water or any cold substance, touching any cold substance. She also complained of multiple joint pain for last 4 months. The joint pain initially involved only the wrist joint, but later also involved other small joints of the hands and small joints of the feet. It was insidious in onset, gradually progressive. It was present throughout the day and night, but more marked after a period of inactivity or rest, and improved by activity or exercise. It was associated with morning stiffness for about 15 minutes. She also complained of shortness of breath, which is present for last 2 months. The shortness of breath was insidious in onset, gradually progressive. It was initially present only after severe exertion, but now the shortness of breath is also present at rest or after mild exertion, corresponding to the MRC grade 4. The shortness of breath is not associated with any diurnal variation or any seasonal variation. There is no history of chest pain, orthopnea, or paroxysmal nocturnal dyspnea. She also complained of cough, which is dry and distressing. It was not associated with any sputum production, and it did not have any diurnal or seasonal variations. So with those complaints, she visited a local doctor who prescribed her some medications which partially improved her symptoms, but she did not have complete resolution. So she consulted multiple physicians, and after that she was referred to BSMMU for further evaluation and management. In further history, she did not give any history of oral ulcer. She did not give any history of photosensitivity, oral ulcer, loss of hair, or alopecia. She also did not give any history of dry mouth and dry skin. There is no history of adverse fetal outcome. There is no history of recurrent deep venous sinus thrombosis. So I'm trying to exclude SLE. I'm also trying to exclude Sjogren's syndrome and the APL, antiphospholipid antibody syndrome. On personal history, she is a housewife. She is non-smoker, non-alcoholic, and on family history, she has two daughters. Both of them are in good health. There is no history of such type of illness in her family members. On the drug history, the patient took some medications. One of them was diclofenac, and she took it for about 7 days. And she also took tablet prednisolone for few days, but the dose of the prednisolone is not clear. She could not properly mention the dose of the drug. Vaccination history reveals that she was vaccinated as per EPS schedule, and she did receive the COVID vaccines. So additionally, there is no history of exposure to tuberculosis or contact with TB patients. So this is all about my history. Now let's go to the examination. On examination of this patient, in general examination, the patient's anemia is difficult to see. The patient has tightening of the skin, especially in the face. The nose has become big. There is hypo and hyperpigmentation in the skin, leading to a salt and pepper appearance. The mouth is small and there is puckering around the lips. The nose is pinched and beaked, and there are some telangiectasias in the face and also in the hands. The JVP is not raised and there is no other abnormalities. The vitals are normal. Then on examination of the musculoskeletal system, I found that the patient, on look, the patient has tight skin. There is no nail fold infarct, or there is no nail fold infarct or any gangrene, but the skin shows tightening, and there is sclerodactyly. There is fixed flexion deformity of the fingers, or sclerodactyly. On palpation, there is mild tenderness in the PIP and MCP joints and also wrist joint, but the temperature is normal and the pulses, the radial pulse is normal and symmetrical in both sides. Then on movement, the patient's movement is restricted. The patient has a limited functional capacity. So the patient has functional impairment. So that is the look, feel, move in the musculoskeletal system examination. On examination of the chest, I found that the patient's chest movement is restricted bilaterally. There is, on auscultation, there is bilateral and inspiratory fine crackles, which is unaltered after coughing. Bilateral, fine, and inspiratory crackles, especially in the base. Better say bibasal. Bibasal, fine, and inspiratory crackles, which is unaltered by cough. So based on the history and examination findings, my provisional diagnosis is this is a case of diffuse parenchymal lung disease. This is a case of systemic sclerosis with diffuse parenchymal lung disease. So in that perspective, we can also say this is a case of diffuse systemic sclerosis with pulmonary involvement. Okay, so that's all.